Welcome and thank you for joining us in the keynote address, Patients' Co-Creation in Future-Proofing Health Systems, Preparedness for Next Phase of the Pandemic.
Welcome, Professor Sanjeev Kumar, to our first session of the day. I'm very excited to welcome you to this session. This session will examine the World Health Assembly Resolution 73.1 COVID-19 response that requires member states to future-proof their health systems by preparing for the next phase of the COVID-19 pandemic. We have two speakers, Professor Dr. Sanjeev Kumar and Mr. Martin Taylor. I will briefly read their bios. You can see more about them on the website. Dr. Sanjeev Kumar is a public health physician with 44 years of experience across 33 countries. He has been in academics and program implementation and has worked in UNICEF for 22 years. He's worked as Director, International Institute of Health Management Research in New Delhi and Executive Director in National Health System Resource Center, providing technical support to the Government of India. He has led development of many policy and strategic documents to improve health in India, including National Health Policy 2017. Dr. Sanjeev Kumar has published over 125 papers in scientific and popular magazines and chapters in books. He's been conferred 12 international and national fellowships and awards for his professional contribution. He is currently Professor Leadership, Global Health and Strategic Management at Inclin Institute of Global Health, Chair of the Indian Alliance of Patient Groups, Indian Academy of Public Health, and Institutional Ethics Committee at the Gautam Buddha University. I think we have an echo. He is also a member of the Governing Board of National Institute of Health and Family Welfare. Could everyone please mute their mics? He is advisor India Health and Wellness Council and Indian Cancer Society and member core committee of the government to prepare health research policy in India. Our second speaker, who will follow Dr. Sanjeev, is Mr. Martin Taylor, who's worked as a strategist, advisor, and manager on global health and development assistance for health for 20 years, with a strong focus on supporting countries to strengthen health systems. He has worked for the UK Department of International Development, including 4 years in Beijing as lead in UK cooperation with China on health systems, HIV/AIDS, and tuberculosis, and was part of the team that established the Global Fund to fight AIDS, TB, and malaria. He studied at the University of Cambridge and the London School of Hygiene and Tropical Medicine. From 2013 to 2017, Martin was the head of the Division for Health Systems and Health Security in WHO office in Beijing, China, in November 2019. Martin joined the WHO Western Pacific Regional Office in Manila as the Director of Health Systems and Services. Welcome to both of you, and over to you, Dr. Sanjeev. Dr. Sanjeev? We can't hear you. Yes, I think you have to unmute yourself. Yes, we can hear you now, but you are muted.
You're unmute. Could you unmute yourself? You muted yourself again.
Oh, okay. Thanks.
Yes, we can. Yeah.
Is that okay?
Yes,
all
we
right.
can.
And do you see my screen as well?
Yes, we can, sir.
All right. Thank you. Thank you so much. It's a pleasure and honor to be part of this important conference. I at times wonder, why do we have to call patient-centered care? Can there be care of patient without being patient-centered? I find it kind of ridiculous that we have to bring it back, that it has to be patient-centered. There can be no health care, no medical care, no health system if there are no patients. So with that, I will proceed with my presentation. We'll talk about COVID in India and how it has helped in some areas to improve patient-centered care, and where are the fault line in patient-centered care in India, and then how do we promote patient-centered care in India. Starting with the good news, the whole world, including India, was unprepared. Health and economy was overwhelmed. In India, we started with restricting and later stopping international travel and restrictions on the travelers who came to India. And we were one of the first countries to start the lockdown when we had only about 550 cases reported. And that did help in delaying the upsurge of cases in India. And during that period, the capacity was augmented. And we were able to later on, when the number of cases increased, address them in a better way. If we had not put the lockdown, we would have been paralyzed because of increase in cases. The top leadership in India took charge. Our Prime Minister came often to talk to the public, clarifying what needs to be done and what is being done. There was open and transparent communication from the authorities. We had whole of government approach. We also had whole of society approach. There was multi-sectoral response. And fortunately for us in India, the case fatality rate from COVID in India was much less than some other countries. To give you a brief overview, what do we have in the healthcare system in India? We have public health sector. We have private sector, which is increasing by the day in terms of proportion of cases they see. We also have indigenous system of medicine. In terms of number of cases they see, it may not be a large proportion, but this is deep-seated in our behavior, cultural beliefs and practices which all of us follow at home. We have many voluntary health agencies, and in India we have large number of national health programs looking after various aspects of health. COVID in universal healthcare in India, for about last 3 years, we have a very ambitious program of health coverage, the largest, in fact, in the world in terms of population covered and in terms of financial allocation. That program is called Prime Minister Jan Arogya Yojana, Pradhan Mantri Jan Arogya Yojana, and popularly referred to as Ayushman Bharat, or many of us even call it Modi Care. So this program included COVID treatment promptly in the initial phases of the pandemic, so that those who are poor, and it covers about 500 to 600 million population in the country, more than half of the population is covered at present. But there were downsides to it. Patients had a tough time in getting hospital admission, as beds, wards, and hospital were reserved for COVID. So non-COVID patients, for example, non-communicable diseases, which are a risk factor for COVID complications, they were finding it difficult to get hospital admission. And even COVID patients at times, the system was overwhelmed, found it difficult to get admission if they needed. Even mothers in labor face difficulties, and we have heard stories of women being delivered in ambulances on the roadside when shuttling between one hospital to the other to find a place to deliver in a hospital. Routine services were initially suspended, but they are still adversely impacted. Outpatient department, the patient attendance is still low. The planned medical interventions are still low. Immunization coverage has come down. Antenatal care, etc., has declined. So we still have services which have not got back to where they were before COVID struck. To those of you who are not familiar with what is the Prime Minister Jan Arogya Yojana, Ayushman Bharat, we have a coverage of about 500,000 Indian rupees per family per year. And 10 crore families, that is 100 million families of poor and vulnerable population are included, which turns out to around 500 to 600 million population. States have been given flexibility to decide how they will implement the program. The benefits are portable. If you fall sick, you belong to a particular place, but you fall sick in another state or another city, it is portable. You can access healthcare even there. And it is a scheme which is based on entitlement. So that scheme came in handy, especially for taking care of the poor and vulnerable. Coming to look at WHO's health system framework, which we use extensively in looking at how the health system is doing. But one thing which will strike you is, though it is looking at access and coverage, quality and safety of the patients, but the patients are implied not there. They should be in the center, as is done in the Government of India's framework. At National Health System Resource Center, the community is in the center, and they have to be in the center. Otherwise, there's no health system to look after them. To look at briefly, what does patient-centered care mean? It looks after patients and patients' families. It has healthcare team, and it has healthcare instructions. So patient is in the center, looked after most often by the family, then by healthcare team, and even instructions given to the patient are implemented by the family at home. And what happened to COVID in India, many other places, it was treated not as a health problem, it was treated as law and order situation. And it was very common for us to see visitors coming from outside India, even Indians who were returning, to be stamped on their hand with restrictions, quarantine time. And then you had these notices put up outside the houses of the people who had COVID patients. Even quarantine in the beginning was put up in front of the door. And the Resident Welfare Association circulated it to everybody. So there was stigma which was reinforced by such measures. And then you had red zones or restricted areas where police authorities took over. Nobody could enter, nobody could leave. So it was treated as law and order situation, putting the patients to a lot of inconvenience. And this brings us back to a wisdom we have been hearing in India about 2,600 years ago. It says, Ayam nija parovetti ganana lagu chetsam udar charita nam subasudhaiv kutumbkam. The world is one family. And COVID has highlighted it very well. During pandemic, no one is safe till everyone is safe. So you have to really look after everybody, not confined to the borders of your cities, your countries, and regions. So everybody has to work towards it to make everyone safe. So this is one message which came back from ancient Indian wisdom and is very true even today's context. One thing which COVID highlighted is the significance of home and family care. Initially, even those who needed quarantine was put up in separate facilities, till those facilities got overwhelmed. So by default, government had to put up quarantined patients at home. Similarly, all COVID positive patients were put in the hospital, and now we know more than half of the patients have either asymptomatic, and another large proportion are mild cases who do not need hospital care. So when the system got overwhelmed, we had quarantine at home. We now have asymptomatic and pre-symptomatic patients treated at home. The guidelines were developed and disseminated. How do you take care of a person quarantined at home? And how do you take care of asymptomatic, pre-symptomatic patients at home? So we have always been struggling that a lot more is done at home. And there was a study published in Lancet, which had costed the economic benefit of home care. And the figure is many times more than the whole expenditure in India at central level and state level. Contribution of women is about 80%. Men do contribute, but only about 20%. So that the value of home care was highlighted, and I hope it continues because it is important in taking care of both non-communicable diseases and also communicable diseases. Many desirable practices which was being preached for a long time came back. For example, hand washing, which prevents respiratory infection, gastrointestinal infection, and skin diseases. I hope it continues even after COVID goes away. Respiratory etiquettes, which were preached for a long time, came back. When you cough into the elbow, folded elbow of your hand. Use of mask for prevention of respiratory and other infection also came back, and I hope it continues and stays with us. Indigenous systems of medicine, we have very strong cultural and belief practices. Though indigenous system of medicine may not be treating a large proportion of cases, but it is deep rooted in our culture and in our belief system. So that also came back, and there are a lot of advisories issued by Ministry of Indigenous System of Medicine. We call it Ministry of Ayush, and also by Ministry of Health to promote some of the practices and beliefs which have been part of Indian culture for thousands and thousands of years. COVID management, let's briefly look at where did we do well or not so well. Unfortunately, most of the answers to these questions are we didn't do well. Patient role is passive or active. I can, from my own experience of reviewing the programs till today, is no, the patient role was not active. They were picked up from home, they were put in hospital, they were not allowed to initially even make phone calls to their friends and relatives, no visitors were allowed. It was more like putting somebody in a jail. Patient is recipient or planner of treatment? No. Later on, when they started doing home isolation, home quarantine, home treatment, yes, to some extent it was put into practice. Patient privacy, we have seen the notices. No, patient privacy was not respected. Given option of treatment to choose from, no, we still have plasma therapy, we still have remdesivir and other medicines which have been proven to be not effective, do not help, and all medicines have side effects, so it will be putting them more at risk than without those medicines. Treatment, medical interventions were focusing on treatment, medical intervention, not quality of life. So initially the answer was no, but later on to some extent started looking at quality of life. Who dominates conversation? It was physicians or our health authorities. Even physicians were bypassed by the law and order authorities, and they took charge. System responsive to patient needs? I would say no. Politicians and bureaucrats became prescribers. There were press conferences in India, as in other parts of the world, where the presidents or heads of the state came forward to promote. We have a chief minister in one of the states in India who was a big advocate of plasma therapy and continues to be a big advocate, diverting resources to setting plasma banks, whereas these plasma therapy is not effective. Unfortunately, some of the technocrats and leading technical experts also speak the same language. 5 reasons we have been seeing highlighted from COVID is equity in access for everyone, everywhere. Quality of healthcare. Safe, effective, and timely care is important. We have delays in hospitalization and unfortunately lives lost because they were not getting treatment early enough. Responsiveness and participation. Efficiency of the system. By wasting resources on interventions which are not effective, we have not handled efficiency of the system well. We have to look at resilience of the system to look after those who have non-COVID conditions and those who have COVID conditions. I think the health system needs a lot of work in India than we would have known before COVID struck us. 5 strategies we need to promote, also highlighted by WHO. Engage and empower people and communities, strengthen governance and accountability. Very important to strengthen accountability. And accountability in this case will go to bureaucrats and politicians because they are the ones who take decisions. But unfortunately, they penalize the doctors and healthcare providers, which is unfortunate. We need to reorient the model of healthcare. We need to coordinate services within and across sectors, create an enabling environment for patient-centered care. Future directions. Pandemic has exploited the existing epidemic of non-communicable diseases. Mortality is much higher in those with non-communicable diseases and those who are elderly. So programs related to these components should have been strengthened even before COVID struck. But hopefully after the COVID is over, even during COVID, they need to strengthen non-communicable diseases and also care of the elderly. We need to have whole of population approach, then only it can be patient-centric. You have a group which is healthy, they have no risk factor, they have no disease. We need to focus on prevention, promote healthy lifestyle, and build resilience. You have second group which has risk factors like non-communicable diseases. They have to follow everything we recommend for group 1, but then the risk factors must, if they have diabetes, they have high blood pressure, these conditions should be kept under control, so that when COVID, if at all, it strikes, it doesn't affect them as adversely. Then you have population with disease, but they are not aware. So screening them and quarantine of the contacts of the patients and those who found positive need to be treated. Group 4 is those with COVID conditions. They need to be treated, provided care. They need to maintain healthy lifestyle even when they are suffering. Then disability limitations and rehabilitation. We have seen long-term sequelae of COVID, and they need long-term attention. Bringing in technology, our former president APJ Abdul Kalam said long ago, strengthening the health system by infusion of science and technology is the top priority to achieve public health. And no government or administration can do it alone. They need to be partnering with everyone, most important being the patients who will use these technologies. Technology to strengthen, we have teleconferences as a way out when we can't meet face to face. Similarly, teleconsultation, telemedicine, teleophthalmology has been started, but it is not reaching the last and the one who needs it the most. We need to address that. We have real-time monitoring. We have vaccine information system even in which you can monitor vaccine in the field till it is given to a beneficiary, and that will help us in COVID vaccine rollout as well. You have initiatives, ANM is online, putting real-time data, and you have many other initiatives. India is known as the pharmaceutical capital of India. Even in COVID time, India was exporting a large number of medicines. We are the leading manufacturer of vaccines. 60% of vaccine before COVID used anywhere in the world came from India. And even in COVID time, most of the vaccine invented anywhere in the world will come for production to India. We have many initiatives being taken by government to promote technology. I have listed a few here, and these initiatives can be used to promote technology. Private sector needs to be stewarded. We have, as this slide shows, between 1995 to 2014,
Dr.
proportion
Sanjeev?
of, yeah.
Professor
Yeah,
Sanjeev,
can we wrap
our
it up? Yeah.
chief guest is ready.
Sure, sure. So we need to steward the private sector, which is becoming more important in patient care. Respect all dimensions of patient care: patient preference, emotional support, physical comfort, information education, continuity and transition, coordination of care, access to care, and giving freedom to family and friends to support the patients. Take home messages: India has handled COVID situation better than many other countries. COVID in India has highlighted importance of patient-centered care. We need more work to make healthcare patient-centric. Private service providers need to be governed and integrated to meet the patient needs, and technology needs to be integrated in patient-centered approach to healthcare. Thank you.
Thank you, Dr. Sanjeev. And it is my privilege now to invite Martin Taylor, Director, Health Systems and Services, WHO Western Pacific Region. Martin, we've already have taken the opportunity to introduce you to the audience. So if you are ready, you can go ahead with your presentation or talk. Thank you.
Thank you very much, Dr. Devi, and I'd like to start by thanking the International Alliance of Patients Organizations for organizing this important second Asia Pacific Patients Congress, and to Professor Kumar for that fantastic presentation that set the scene. Good morning, good afternoon, good evening, everybody. It's a great pleasure for me to be here today at this very important second Asia Pacific Patients Congress. 2020 has been a really extraordinary year. Millions of people around the world have been infected with COVID-19. Millions more have been affected with their livelihoods lost. Many have been critical ill in hospital, and sadly, many have lost their lives. I think it's only fitting that today, as we're gathering to explore the role of patients in creating health systems for the future, that we begin by acknowledging and paying tribute to all of those who have suffered so much in 2020. Also, I'd like to take this opportunity to acknowledge the vitally important role that all of you here today have played in 2020 during the COVID-19 pandemic. Your tireless work has been invaluable and vital, supporting your families, supporting your communities, supporting your healthcare systems and your healthcare workers to respond to COVID-19, and at the same time continue to provide essential healthcare. The vital role of patients, families and communities in healthcare has long been recognized. However, it's often difficult to materialize it in actual healthcare. COVID-19, however, has hugely emphasized the importance and also shown some ways in which we can all move forward. For patients, families and communities have played a vital role in our collective and societal responses to COVID-19 and in engaging health systems to ensure that together we can improve them for the future. The COVID-19 pandemic has stretched health systems to the limit. At the same time, it has brought the role of patients and communities to the fore. Every one of us is a potential patient, and every one of us has the motivation to be involved in combating the pandemic. And all around the world, we have seen examples of populations stepping up to do so and to play their role. Regardless of where we are in the world, we share the same vulnerability to COVID. As we continue to respond to the pandemic, health systems have been at risk of being overwhelmed. And sadly, in some countries, they have been overwhelmed. Health workers themselves have been infected. They have become patients, they've been sick, and they've been driven to exhaustion. Mental health of health workers has become a globally recognized issue of concern. However, what we see is that measures to respond to COVID-19 rely very much on a combination of both individual and collective behaviours and responsibilities. Wearing a face mask, practicing physical distancing, hand washing. These are individual actions that everybody now recognises can protect not just ourselves, but also others. And it's extremely clear that an effective response to COVID-19 requires governments, health systems, populations, communities, patients, all of us to work together. Trust is central to this. In our Asia-Pacific region, we've seen community engagement become a key strategy in the COVID response. We've seen that include communities identifying their own local appropriate solutions to COVID-19. We've seen communities involved in raising the awareness of COVID-19. We've seen champions locally recognized and identified who support and lead the local response. We've seen communities involved in alleviating mental health issues, not just of health workers, but of patients and of the broader population. This has been vital and I think highly recognized. Patient appreciation has also been a major source of motivation to health workers at the front line. So at this time, as we come to the end of the year, we see many challenges, but also some opportunities and positives to build upon. In many countries, as I said, the pandemic has brought to the fore the importance of strong and resilient health systems. Never before have we had the attention of finance ministers, prime ministers, presidents, leaders of multilateral development banks, the IMF, all focusing on health. This gives us a wonderful space to be able to actually build the healthcare systems that we know we want to build for the future. While combating COVID-19, we must continue to ensure that people continue to have access to healthcare and other services that they need. People still need diagnosis and treatment for tuberculosis. Women and mothers still need to receive maternal and child healthcare. Children still need to be immunized. Patients with NCDs and chronic conditions still require access to diagnosis and safe, quality care. And we've seen examples in our region of how communities have stepped up to mobilize themselves to be able to support those who need interventions. So, as we turn to the future, how can we build and learn from this? I think maybe we should start by saying that our vision for the future is one in which health is a core value in society. This includes, of course, strengthened healthcare systems as part of countries' efforts to achieve universal health coverage and the Sustainable Development Goals. It includes recognizing that there isn't a choice between economic growth and health, but those two come hand in hand. And as we increase one, the other increases and vice versa. Our vision should, of course, include that everyone has access to the quality healthcare they need when they need it without fear of impoverishment. Our vision should include that health workers are fully recognized and adequately compensated for their work. And our vision should include involving communities in protecting and preserving their own health, as well as their role in working to build health systems for the future. Our vision, as I said, is a vision of a society which values health and protects health, that has health as a core societal value. We have a great opportunity now to learn the lessons from COVID-19. And one thing that is very clear is that our vision will only be possible if patients and patient groups and communities engage and are engaged, both in shaping that vision and advocating for a vision in which health is at the core of society's values. And also that vision is only possible if patients and patients groups and communities are engaged and fully engaged in designing the healthcare systems of the future. We can look a little bit to the Patients for Patient Safety programme to provide an avenue for patient voice. We can look to the frameworks for integrated people-centred health services to provide a framework for engagement. We can refer to the important declarations on primary healthcare from Almaty. But those provide us our high-level framing and vision. Our task is to make that a reality. And so I really hope that this Congress can help take those guiding principles, shape a vision, and explore how we can transform the enthusiasm and the experience among patient and peer groups during the COVID response, and make sure that that carries into the future in terms of future health and future healthcare. We're meeting now at a time when the development of COVID-19 vaccines is beginning to offer us all some hope. But we know that that hope is not of an immediate transformation. It's going to take time to roll those vaccines out until they have reached all corners of this globe. We also know that their successful rollout depends on extremely effective engagement with patients and patient groups and populations to make sure that there is trust in those vaccines, to make sure that there is not misinformation, and to make sure that people will readily and willingly come to have those vaccines. This gives us a great opportunity to begin to cement some of those roles of patients and patient groups and communities in delivery and planning of healthcare for the future. So, in conclusion, I would like to say that we all now have, at this moment, a huge opportunity to shape a vision for the future. From WHO, we of course think that that future should have health as a core value in society. And we would like to work with all partners to build that vision and build that future in every country in our regions. We all have the responsibility to shape this future. So I'd like to conclude by thanking you all for the vital role you have played so far in the COVID-19 response, and thank you in advance for the vital role that you will play in ensuring that there is successful COVID vaccine rollout that reaches all populations, and especially, of course, those most vulnerable. And I look forward, on behalf of all of WHO, to working with you as we create a new vision, what we hope will be a healthier vision, which puts health as a core societal value and make sure that we have adequately funded healthcare systems to make that a reality. So thank you again for inviting WHO to participate in this Congress, and I wish you all successful discussions in the coming days. Thank you very much, Dr. Devi.
Thank you, Martin. Thank you for that very inspiring speech, and also for shaping the vision, saying that health has to be at the core of societal values. That is where the patients want to be, that health is integrated into everything. So it's an all of society, all of country approach in its true sense. I would now like to invite Professor Sanjeev to say a few remarks and this session to the audience. Let me say, because it is a keynote, it will not take any questions and answers to the panelists. So Professor Sanjeev will try and wrap up what has been spoken over the last 40-45 minutes, and then we will move on to the next session. Over to you, Dr. Sanjeev. You are muted, Dr. Sanjeev.
Is it okay? You hear me now?
Yes. Yes,
okay.
We can.
There are 5 things I would like to re-emphasize, and thanks Martin Taylor for excellent presentation. These 5 things are: you have to have patient-focused healthcare, and it is more important even in pandemic. So we need to correct whatever problems are there. Safety of patients and healthcare providers. In India, unfortunately, 500 medical doctors have lost their lives for COVID. So it's very important to do that. So you emphasize safety. Individual and collective action is the 3rd point I would like to say. And Dr. Ratna also mentioned about whole of society and whole of government approach to that. 4th, community engagement is very, very important. Without community engagement, you cannot handle pandemics. The community has to mobilize all resources and help the system. 5th, silver lining to this black cloud. We have opportunities. We have identified what are the gaps in the health system. We have also identified what are the gaps in public health. For example, in India, it is not public health experts who run the control measures in pandemic. So we need to bring them back. We need to look at access to non-COVID condition. when pandemic comes, if you have a good access, even for those epidemic you will have. And we have what is called syndemic. We have an epidemic of non-communicable diseases. On top of it, COVID. So it's referred to as syndemic. So one epidemic over another epidemic makes things much worse. Thank you so much.
Thank you, Dr. Sanjeev, for wrapping it up so well. I will now declare this session closed and will request the participants to move on to the next session, which will start in a few minutes. Thank you, Martin, and thank you, Dr. Sanjeev, once again. Thank you so much for being a part of this opening session. Thank you.
Thank you. Thank you so much.
Thank you.
Thank you.